Well, hello there and good evening. Top of the evening to you, America. My name is Dr. Randy Fink, and this is Fertility with Fink, your one stop shopping place. Every place that you need to be is right here, right now, every Tuesday evening at 5 p.m. We are 5 p.m. In the Central Time, which means 6 p.m. on the East Coast and 4 p.m. in the mountains, 3 on the west. My name is Randy Fink, and I am the fertility gynecologist here at New Life Fertility in Pensacola, Florida. And it is a great pleasure to be with you tonight, as I am on every Tuesday, to say hi, welcome. It's your happy place, it's your safe place, it's the place where you need to be to talk about all those things that are important. Right here, along with my partner, Dr. Barry Rips at New Life Fertility in Pensacola, Florida. We really strive to go the extra mile to make this fertility thing something that you don't have to worry about. Let us worry about it for you. And let's see if we can get you to that place of having the family that you've always dreamed of. We've got 3 different feeds right here. We've got Facebook, YouTube, and LinkedIn over on this camera. We've got New Life Fertility right here. We've got my Instagram right here, and that's Randy Fink MD. Feel free to join in. I try to get to all your questions tonight. If for some reason I am not able to get to your questions, because they tend to start to pile on a little bit later, the email address is askfertilitywithfink@firstfertility.com. That's askfertilitywithfink@firstfertility.com. And we will tackle those questions at the top of the next show if we're not able to get to them tonight. So let's say hi to all of our friends who are joining us here. SD Rosie, thanks for being here. Sharmilla, thank you for being here as always. Hello to Kenzie. Kowser, Lexi Younts, pleasure to see you up there in the Carolinas. Nurture Chana, good evening and welcome. Let's see. Rosie says, thanks for being here, Dr. Fink. It's my pleasure. Hi to Monica and Bryn. We've got Sarah on this side. We've got, Lori Rips, the famous Lori Rips right there, who is a wonderful physician in her own right, wife of Dr. Barry Rips, who works with me here at New Life, and Plant Hunties is here as well. We've got some friends who have joined us on the Facebook and LinkedIn side, as well as on YouTube. And let's just jump right into some questions here. These were some questions that came in through the email. And by the way, that email address is askfertilitywithfink@firstfertility.com. Shanna asked, what do we know about SSRIs or antidepressant medication in pregnancy? And it's a great question. Shanna shared with me that she is early pregnant now. So far, so good, but certainly being plagued with feelings of anxiety, and that's not unsurprising after going through so much in order to be there. To tell you the truth, there are very high levels of anxiety associated with certainly folks in the fertility world who get pregnant, but to tell you the truth, pregnancy itself is a very high anxiety state. So it is not at all unusual to see pregnant women on antidepressant therapy. We know antidepressants are a very safe form of medication, and in fact are one of the most commonly prescribed medications in our world today, certainly at least in the United States. And so the experience is not limited as far as women being on antidepressants in pregnancy. In general, they are a safe bet. They have been studied pretty thoroughly. There are really relatively very low risks for complications associated with these medications in pregnancies, especially medications like Prozac and Zoloft. Now, Paxil or paroxetine has been shown to have a slightly higher rate of certain types of cardiac defects, but fortunately, again, they are really pretty rare to see. So I would consider them safe. Furthermore, there might be an issue with a baby being born and having some problems related to things like irritability, um, uh, being a little irritable and having to, kind of get those medications out of their system. That usually passes within a very short period, like 2 or 3 days. So typically, it's not something we feel like we have to worry about too much in that regard. And the question there really is you're having to balance out um, um, which is going to be worse, a very theoretical, very low risk for an association of something with a medication, like let's say irritability that lasts for a couple of days in a newborn, or an extremely low risk for certain types of birth defects, let's say cardiac birth defects. And again, fortunately, very, very low, versus the very, very real probability that your pregnancy will be both extremely uncomfortable based on the mood disorder, as well as the associated elevated cortisol levels and things that happen in your body as a result of that mood state. Those things with untreated depression and anxiety can be problematic in and of themselves. And so, with any medication, we always have to evaluate the risk benefit ratio. And in most cases, the benefits of the selective serotonin reuptake inhibitors, or the SSRIs, such as Zoloft, exceeds the very small risk. So I hope that that's helpful. Naiha, if I'm saying it correctly, asks, well, when does one think about canceling an IVF cycle? And she shared with me some of what she's going through in her IVF cycle, where she's doing it, and it sounds like she was really hoping for better outcomes, and had just a few follicles. And so, really, the question is, well, when do you say, look, I'm not going to go through with this, I'm not going to do the retrieval? And the answer to that has to be really very individualized, because part of that is going to depend on, well, really kind of where is your AMH level, the anti-Mullerian hormone. And that tells us about what can we expect in terms of your response to the medications. Are we expecting a great response, but we're getting a very minimal response? Well, in that kind of scenario, I might say, you know what, maybe we need to regroup and figure out what's going on here so that we can try to do a better job with another stimulation. However, if the ovarian reserve is low, then and when we're only getting a few follicles, that may really be all that we can expect to get. And so in that scenario, you would say, well, I'm going to go for this, because even if I get just a couple of eggs, that's more eggs than I might have otherwise gotten, and I can proceed with this process in order to make some embryos. So, Neha, I hope that that helps you there. Amy asks about treatment for endometriosis, and how does that change in terms of IVF. So, if we know that you have endometriosis, the best evidence tells us that suppressing that endometriosis, that is turning off the hormonal supply to the endometriosis, um, is beneficial prior to doing an embryo transfer. And the way we know that is because there is a non-invasive way that we can test for endometriosis, and that's called a marker that's known as BCL6. Well, if you have a euploid, a tested chromosomally normal embryo, then we know that embryo has about a 65% probability of being able to get you a pregnancy. That's really the best results that we can hope for with IVF. 65% probability of pregnancy with a euploid embryo. If your BCL6 marker is positive, and that's the marker for endometriosis, and it comes from a test that's called Receptiva. If that test is positive, we know that 65% number drops to really less than about 10%. So the effect is pretty significant of the endometriosis. So what do we do about that? Well, I think the right thing to do is suppress that with medication. And that medication is either Lupron. Lupron literally pulls the plug on your hormones and turns off the food supply, the hormonal food supply, if you will, to endometriosis. And the recommended treatment there is about 8 weeks. 8 weeks or 60 days of treatment with hormonal suppression will turn off that BCL6 marker. The other thing that we can do is an oral medication that's called Orilissa. Orilissa is a pill that you take that similarly suppresses endometriosis and will negate that BCL6 marker. And when you treat that BCL6 positive, or in other words, the endometriosis for 8 weeks, you can increase the probability of that 65% euploid embryo all the way back up to its full potential of 65%. So that's how we know that this does make a difference. And that is generally the approach that I take for folks with known endometriosis. It just improves the outcomes. Amy also asks, is there a limit to the number of embryos that you can transfer? And the answer there is yes. So there's a guideline that we typically follow, and that comes from the American Society for Reproductive Medicine, the ASRM. And you can look that up. It's just Google ASRM embryo transfer guidelines, and that will tell you about the number of embryos that we recommend, the maximum number that we feel like you can transfer. Our goal is really always to get you one healthy baby at a time. There are lots of folks who enter the process here saying, well, I really want to have twins. And we say, okay, we don't want you to have twins. And you say, but I want to have twins because it'd be so easy to get through that process earlier, have my two kids both at once, and that just saves me time. Why wouldn't that be a good thing? And the answer to that is, well, generally speaking, it's not. There is a higher risk for birth defects. There is a higher risk for autism. There is a higher risk for brain injury, for severe preterm delivery, for prolonged NICU stays, and lifelong disabilities associated with multiple gestation. Yes, even twins. So everybody knows somebody who has twins in their family. And yes, it's the idea is very endearing. It sounds like something that you would, in theory, maybe like to do. You can dress them up together. They're very cute. You buy a lot more diapers. You get more baby food, but you get through those earlier days faster. And the answer there is no. We just don't want you to do it for the reasons that I've explained. So the entire ASRM guideline over how many embryos to transfer is really based upon our desire to get you one healthy baby at a time. So thank you, Amy, for that question. And Sandrine asks, when would one start Lupron for suppression? Do I have to start when I get my period? And the answer to that is no. In my book, I would say start as soon as you get the Lupron, because you're going to take the Lupron, it's going to shut everything down, and the clock will start ticking much faster for you to be able to get through that suppression and get to your embryo transfer. Sandrine, best of luck to you. If I don't get to your questions tonight, those all came from the email. It's askfertilitywithfink@firstfertility.com, and we will get to yours top of the show next week. How you doing tonight? How has your week been so far? How was your weekend? I will be honest, mine was a little bit stressful. I've got a parent in the hospital, and that is never a good thing, but she is doing very well, and hopefully will be coming home in the immediate future. And we've got IVF egg retrievals this week here at New Life Fertility, so we're all working very hard. So let's see who we've got here and what questions we have on my Instagram, which is Randy Fink MD. It looks like the first coming from SD Rosie. SD Rosie, P.S. You were the very first person to log into the program this evening, so you get a gold star. Ding! Thank you very much. I did not start my baby aspirin due to a subchorionic hematoma, which is still there at 18 weeks. No bleeding since 8 weeks doesn't mean I'm at risk for preeclampsia now. I just turned 43. Well, so it's an excellent question. We typically use aspirin for a couple of different things. One is we know that it does help to prevent some clotting episodes that happen in the small blood vessels that supply your that supply your placenta. But in the mainstream obstetrics, we have shown that aspirin, or really even just a baby aspirin a day, is enough to have a preventative effect on certain hypertensive disorders in pregnancy, specifically preeclampsia, like you mentioned there. So, in the general population, it has never been shown that taking a daily aspirin will prevent preeclampsia. However, we like to use that aspirin to prevent preeclampsia in someone, or as a potential preventative effect for preeclampsia in someone who has a history of preeclampsia. Does that make sense? So, given that, I'm not sure if you have a history of preeclampsia, but when we do medicated cycles, medicated embryo transfers, there is in IVF, there is a slight increased risk in those hypertensive disorders in pregnancy. So to me, it seems like a baby aspirin or an aspirin a day is a good thing. Now, in your case, and you changed your handle, SD Rosie. I know who you are. The subchorionic hematomas in most cases do resolve. And if you haven't heard me talk about that before, a subchorionic hematoma is a little collection of blood that exists underneath the placenta. It's one of the more common reasons that folks have some bleeding in the first trimester. And like any bruise, they typically do go away on their own. Sometimes they are still there. Sounds like in your case, Rosa, that yours still is. But I think that you are probably better off without that aspirin, given that the hematoma is still there, because there's no reason to pull the tail of the tiger, as we say. Hello to Erica and the Stiles family. Sharmila asks, my sister's AMH is 1.25 and she started her IVF. Her follicle count is 3 on the left and 1 on the right. Why is it a lower follicle count compared to last month? Well, what you're talking about is something that's called an AFC, or an antral follicle count. To be honest with you, the AMH level is generally more predictive of how you're going to do with IVF, because the AFC, or the antral follicle count, is considered it's both non-sensitive and non-specific. Now, certainly if you've got a whole bunch of follicles sitting there in the ovary at the beginning of the cycle, we would say, well, that may speak pretty well to you being able to generate a whole bunch of follicles for us to retrieve eggs from. But just because they are absent, or because that count is low, doesn't mean that you're not going to be able to make eggs, especially with an AMH at 1.25. Now, here's an interesting phenomenon. Let's talk a little bit about that AMH. The AMH, or the anti-Mullerian hormone, is a hormone that's secreted by a group of cells that surround every little egg in the ovary. And remember, you're born with every egg that you'll ever have. And it's kind of not a fair thing that the sperm that comes out from the male partner today was generated in his body about 3 months ago. But every egg that you'll ever have in the ovaries is right there at the beginning of your life. So the more of those eggs you have, then the more of those cells that you have that surround the ovary. And the more of those cells you have that surround, not the ovary, but surround the egg, the more of those cells you have, the more AMH you have. So if we looked at a curve that we start off, let's say at 15 years old, and all the way up to, let's say, 50 years old. Your highest level of AMH is going to be up here at the 15-year-old mark, and over the course of our lives, it just kind of goes down. We ovulate some of those eggs, but most of them we ultimately end up just kind of losing to the process of aging. So as those eggs disappear, as they regress, we have less AMH, and if there's less AMH, that's how we kind of predict the overall ovarian reserve. What you see at the beginning of a cycle may vary cycle to cycle, because it depends on the number of little follicles or eggs that have made themselves available to be recruited. And that's what happens by nature. Now, in IVF, we're giving you medication to help recruit those eggs. We're giving you follicle stimulating hormone, which is the hormone that tells the brain to tell the ovary, bring it on, give us more eggs here. So in that scenario, what you see is not necessarily what you get, Sharmila. So hopefully that's helpful information, and our fingers are crossed. Best of luck to her. Is it not advised to continue the pregnancy after 39 weeks for someone who is 43 years old? Is it better to induce before reaching 40 weeks? So the timing of delivery has been a long-term topic of debate. And what we know is that if you make it to 39 weeks, which is going to be obviously the week before your due date is 40 weeks. Now, why do OBs always talk to you in terms of the number of weeks pregnant you are? Because that 40-week mark is actually 10 months, not 9 months. So we're always going to tell you the number of weeks. Your due date is calculated at 40 weeks. And you may have noticed that as you get more pregnant, ultrasounds become less accurate. Your due date is going to be based on either the known conception date, which is what happens in IVF, or if you conceive spontaneously, based on the very earliest ultrasound that you have, or based on if you're sure about the date of your last menstrual period. So 40 weeks is the number. We do not like to deliver folks before 39 weeks unless there is a very clear medical indication. And that's what we call, near-term pregnancies. Technically, anything after 37 weeks is considered term. And so if you went into labor, let's say at 38 weeks of pregnancy, well, that's all, really well and good. But if we were going to try to get you to deliver your baby, let's say we wanted to induce your labor, we would always now wait until 39 weeks. And that's because there is a very clear increase in the chance that the baby ends up having to stay in the NICU for some reason. Maybe the baby hasn't figured out how to regulate blood sugar yet, or how to stay warm enough, or the lungs aren't fully mature, or maybe there's a little extra fluid in the lungs. All the reasons that babies can end up staying in the NICU, that risk is higher if you deliver before 39 weeks, especially if you have been induced. So there was a very strong movement in the mid 2000 teens to move. Actually, no, even before that, probably around 2010, to try to get folks to move towards no more elective inductions of labor before 39 weeks. Now, if your cervix is favorable, which means it's already open, it's starting to open, it's soft, it's starting to thin itself out, and the baby is well engaged in the pelvis, and that's what we call a favorable cervix, then beyond 39 weeks, there is no advantage to you remaining pregnant. Now, most practices do not prefer you to go beyond 41 weeks of pregnancy, because the data shows us that after 41 weeks of pregnancy, bad things tend to start happening. What does that even mean? Well, the placenta is an organ that ages, and it has an age of, roughly about 40 weeks. And so once it starts to get tired, less blood flow goes through it, things can start to happen. And so beyond 41 weeks starts to make most obstetricians a little bit more nervous. As far as IVF goes, there's nothing specific that says, oh, you have to deliver at some certain point. And if you are what they euphemistically call advanced maternal age, which means anybody who's over the age of 35. And like, that's advanced age? Holy cow. Well, that term, advanced maternal age, really comes from before we were so readily able to detect chromosomal problems in pregnancy. If you're over 35, it used to be recommended, that you really need to have an amniocentesis so that you can make sure that you're going to be having a chromosomally normal baby. And that risk cutoff point was 35. And so that was always called advanced maternal age. all the more reason with advanced maternal age or at the age of 43 that I would say, well, beyond 41 weeks, I would not want you to go. And I would start to get nervous even, 40 and a half weeks beyond your due date. But the ultimate answer is that if your cervix is ready, there's no advantage to you staying pregnant even up till or certainly beyond your due date. And I hope that helps. All the best there. Hello to Sheila and trying to conceive for baby chambers. Nice to see you. Mara is here as well. Thanks to Shalistar Ramsey. Thank you for saying such nice things on the Facebook side. Appreciate that. Glad to be here for you. If you've just joined, we are approaching half past the hour on Fertility with Fink every Tuesday night. Every Tuesday at 5 p.m. Central Time, we are here in this place from New Life Fertility in Pensacola, Florida, to answer all your fertility and IVF and just general women's health questions. Let's see. Kowser says, hi, Doc. On my cycle day 1, my estradiol level is 307. Okay, so I would say 307 is a little high for the start of a cycle, and that suggests to me that you still have some cells in your ovary, probably in a little cyst, that are making some estrogen. And you say on my left side, I have 7 follicles, and on my right side, I have 3 follicles with one big follicle of 20 millimeters. And on cycle day 4, my estrogen level is 111, and my egg count dropped to 3 on the right side. Okay, so what happened there? You had a little extra stimulation, it sounds like, that probably came from your own body that caused you to make that. I bet you that 20 millimeter follicle is gone. That's probably what was making your estrogen there. And that's what caused that estrogen level to be a little bit high. Once that regressed, probably some of the other little follicles may have regressed with it as the estrogen level was kind of going down. I think that's probably what happened in that cycle there. Because, as much as we try to control things. And I'm not sure if you're doing IVF or IUI or what your plan is there. But when we give you stimulation, we always kind of want to be in control of what the ovaries are doing. There's only so much controlling that we can do, because your body writes its own rule book and it's going to do whatever it wants to, whenever it wants to. So I always say the least trained ovary is still much more in control than the smartest doctor. And that is an unfortunate reality of what we do. Hi to Olive Lynn. Thank you for being here. I had a low. Here comes from this from Sharmilla again. Thank you, Sharmilla. My AMH was lower. It was 0.77, but you put me on Omnitrope, which gave me a good follicle count and quality as well. Could we try Omnitrope for her? That's a great question too. And let's talk about human growth hormone, which is what Omnitrope is, a brand of human growth hormone. So human growth hormone has been really studied pretty, I won't say extensively, but there have been a number of studies looking at human growth hormone to see how does it help us in terms of fertility. And to be honest with you, most of the studies are not really all that favorable. They really haven't shown us great things to happen as a result of using growth hormone. So what is growth hormone? Growth hormone is what keeps us young, right? As we mature. See, because I personally don't age, I only mature, although many people would argue otherwise to that stated fact. I'm not sure if I've matured probably since I was 15. So have you ever noticed guys' sense of humor always stays at around that of a 14-year-old boy. But as we age, as we mature, our growth hormone levels will start to drop. And that's one of the things that contributes to what we know of as cellular aging. So the thinking is, well, if we can give you some growth hormone, then maybe we're helping some of those eggs in the ovary that are a victim of the process of aging. Because, as we age, the stability of the DNA in those eggs starts to get shaky. And as the DNA becomes less stable, if there was something that we could do for you that would help to stabilize some of that age damaged DNA, then wouldn't that be a great thing? Then we could improve egg quality. So that's the goal with using human growth hormone. Well, what are the problems there? The studies have been very equivocal. There's some studies that say, oh gosh, it makes a great big difference. And there are other studies that say, no, you know what? It really doesn't make much of a difference at all. Were it not for the fact that it's really expensive, then I'd say, sure, let's put everybody on growth hormone, because empirically, in my own personal experience with IVF, I would say I think it probably does. It certainly does seem to make a difference. And Sharmila, you are a great example of that. It really, it did make a difference for you. The problem is that, well, so I think the reason that the studies are equivocal is because we have yet to really identify, well, exactly who are the people who will benefit from that growth hormone. Is it folks with a normal ovarian reserve but poor egg quality? Is it folks with a low ovarian reserve but poor egg quality? We just don't really have the answers to that. And studying these kinds of things in humans is very hard. It's very hard to do prospectively, which is the best kind of research we can do. And when you look at it after the fact, there are often so many variables that go into that, it's really hard to say what made the difference here. Again, in my opinion, I think it does make a difference. So, Sharmila, I would say yes, absolutely. If there's a concern about egg quality, growth hormone or omnitrope is a very good idea, albeit potentially one that's expensive. So everybody also has their own little protocols for how to use growth hormone. The protocol I like to use is about 6 units a day for approximately I like to do 21 days before the start of the stimulation, and then during the stimulation, which is 9 to 12 days. That amount of growth hormone through the fertility pharmacies should cost roughly between $600 and $700. And gosh, that is it's a lot of money, to have to spend on something that doesn't have a proven benefit. But if you were to take that same prescription to CVS or Walgreens, for instance, that same growth hormone might cost you $2,500 or sometimes even $5,000, which is outrageous. Growth hormone is actually intended for people with congenital short stature or with inborn growth, adult growth hormone deficiency. So yes is the answer there. Hey to Dancer, nice to see you here tonight. Does autoimmune Hashimoto's thyroiditis cause a decrease in the count of eggs? I would say no, probably not so much, because usually Hashimoto's or autoimmune thyroiditis, which is where you develop an immune response, an antibody against your own thyroid gland, that's typically a situation that just creates an increase in inflammation, and that can result in egg quality issues and certainly in implantation issues. However, I would think that's probably more the concern than an egg quantity issue or a diminishing number of follicles that you see in an ovary. Hey to Tracy in Miami. Hey to Zenny in Miami. Thank you so much for being here on this Tuesday evening. Let's see. Hi to Mandy and Marlena. It looks like I can't say it out loud. Jasmine, thank you for being here. Mrs. Vance in Kentucky, thank you as always for being here. Angela asks, what are your thoughts of using Gonal-F for a frozen transfer to help with the lining. So basically what you're asking is, what kind of tricks do we have? What can we do for folks who are not building up a thick enough lining for their embryo transfer? And what does that really mean? Well, you know, the lining of your uterus, right? It has one job, and its job is not to give you a period every month, even though that's sort of the side gig. That's its side hustle. But really, its principal goal is to give you enough of a spongy, warm, juicy place for an embryo to implant. That is its sole reason for being there. And when we give you estrogen and you don't build up a lining, that can be for a number of reasons. Sometimes it happens because there's been some damage to that lining. Sometimes it happens because there's a problem with the receptors for your estrogen. So your body is talking with estrogen, but your uterus isn't hearing it. And in that situation, yeah, you don't make enough. So really the magic number we're looking for is generally in most programs about 7 millimeters of lining. We want that lining to measure at a 7 in order to consider it thick and juicy and warm and spongy enough to be able to implant a pregnancy. So that's the number we're looking for. When you don't build that lining, there are some different things that we can do. There are some different medications. Sometimes we'll use oral medications. The use of tamoxifen, which is a drug that's used to treat breast cancer, can help to thicken the lining when taken for a few days. Sometimes even just a simple aspirin will increase the blood flow to that lining so that it will thicken up. Straightforward estrogen generally does it, unless it doesn't. We can use some Viagra. We'll often use compounded vaginal Viagra in order to help the blood flow that's going to the uterine lining. We can use intrauterine PRP, or platelet-rich plasma. And yes, indeed, we can use stimulation we call gonadotropins, such as Gonal F or Follistim, to aggressively get you pardon me, to create a follicle in the ovary, because that's where your body's own natural estrogen comes from. So that is an option, and that's something that we would use in what's known as a modified natural type embryo transfer, or frozen embryo transfer, as opposed to the medicated one, which is where we're giving you the estrogen. Now, I will tell you that there are many cases I've seen where we give folks all this estrogen, this pharmacologic doses of estrogen. I personally like using estrogen pills. In my practice now, very commonly they use estrogen patches. But for one reason or the other, sometimes people's bodies don't hear that estrogen, and the lining doesn't grow. So sometimes if you don't do anything at all, or you just induce a little ovulation, the body will make its own follicle. And that follicle, as it grows, is surrounded by some cells that are called granulosa cells. Those granulosa cells are where you make your estrogen. That's where your body gets its estrogen from. And so you may make your own estrogen just fine, which your body hears just fine, and grows a really beautiful and perfect lining. Whereas when we give you all that estrogen from the outside, maybe it doesn't respond. Think about it as a lock and a key. Your key is looking for that perfect lock. Where does that... Wait, your lock, I got that all wrong. Your lock is looking for that perfect key. Where does that perfect key come from? It comes from your body. Your body knows how to make a key for your lock. When we're giving you medication from the outside, we are using, even if it's what we call bioidentical, it may not be completely identical to what your body would naturally make. And so that's the reason there. But yes, Angela, Gonal F for a frozen transfer will cause you to make follicles on your own, which will cause you to make your own estrogen, which will in turn cause you to thicken up your lining nice and juicy. Now, I will say that's an expensive way to do it, because as you know, Gonal F is not cheap. So that's typically not the first place I would go to try to help build up that lining. Hi to Tara. Nice to see you this evening. Mohi, thank you for being here. Hello to Nina and Karen and Kat B. Mohi says, hello from sunny San Diego. It's nice to see you in San Diego. I am 48. Do you recommend PRP of the ovaries? So, what we're talking about there is intra-ovarian PRP. Are you familiar with PRP? Platelet rich plasma. So, what we do with platelet rich plasma is that we draw a tube of your blood and separate out your body's healing components, your tissue factors. And that's what's called PRP. Normally, when you take a tube of blood and you spin it down, those healing factors fall away into the red blood cells. If you've ever seen a tube of blood get spun, you get a bunch of red cells at the bottom, you get a bunch of clear fluid at the top. That clear fluid at the top is called the plasma. Well, if we can keep the component of your blood called the platelets in that top part, that's called the plasma, then the growth factors, the tissue factors, stay with the platelets, and that's what platelet-rich plasma is. It is the most soothing salve that your body can make, and it comes from your own body. So we can do a bunch of different things with PRP. You can put it into the scalp and help regrow hair. You can put it into a damaged joint and potentially help that joint to heal. We use it in facial aesthetics. You can use it with filler. It helps to prolong the life of the filler. There's something that's called a vampire facelift, which is where you're literally injecting that PRP into the face to do things. Well, we can use it inside the uterus because it helps the uterine lining to grow. But what we're talking about now here with your question is intra-ovarian PRP. What happens when you take those tissue factors and place them directly into the ovaries? How do you do that? Well, usually you do it like you would with an egg retrieval. Patient gets some sedation so nothing hurts, and then with a vaginal ultrasound guided procedure, we can inject that PRP directly into the ovaries. So the needle goes into the ovaries. Usually when I do that, I like to fan it out over the course of the ovary because the remodeling that takes place as a result of the tissue injury that's happening from the needle and the return of your plasma to the ovary is one of the things that's said to benefit that tissue. Now, the problem with intra-ovarian PRP is that the data is very plus minus on it. And again, I think the question there is who is the right candidate for intra-ovarian PRP? And that's a hard thing to put a finger on because in your situation there, Mohi, if I'm saying it right, Mohai, I apologize if I am mispronouncing. At 48, we know that the odds of you having a normal egg in your ovary is going to be, well, really, frankly speaking, it's going to be pretty low. And that's why women in nature rarely get pregnant on their own at 48 years old. Now, it can happen. It happens all the time. We certainly do see it. So it's far from impossible. Many programs doing IVF will have an age restriction because the odds of being able to conceive through IVF beyond the age of about 44 or 45 are really very low. And so there's some ethical issues with, well, should we, should someone be able to take your money for something, to do a procedure and to put you through a procedure that may have such a very low chance of actually working. My feeling on that is that if you want to give it a try, I'd say absolutely. I think it's worth giving it a try so that you can see yourself how your body is going to respond. Most programs at 48 would say using a donor egg gives you a very, very high probability of being able to get pregnant. And so that's where they would try to lead you. But if you were going to use your own egg, could intra-ovarian PRP help your body to stabilize some of that age-damaged DNA? In my opinion, I think probably so, because that seems to be the way that it works. And so, if there's something that you can do to help with that, then yeah, I would certainly want to do it. There is also a supplement protocol, and that is in my book called The Vitamin Victory, which you can find looking at my link tree, which is on my Instagram page, and that's Randy Fink MD. But the link tree is linktr.ee/Randy Fink MD. The Vitamin Victory talks about that evidence-based supplement protocol, and I would certainly recommend that you, at the very least, be on every single one of those supplements for diminished ovarian reserve, which is what I would expect, an age-related diminished ovarian reserve at 48. But would PRP do something for you? I think it certainly would be worth a shot. But again, we don't know the answer that PRP is best for someone who has a lot of eggs. There's just an egg quantity, or rather an egg quality problem, whereas the quantity is fine. We know that PRP is not going to make you any more eggs, because again, you're born with all those eggs that you'll ever have. But can we help to stabilize that age-damaged DNA? That is the million-dollar question. So PRP, I certainly think, is something that is in our armamentarium that may make a difference. Hi to Lucy, Dr. Russo. Thank you for being here this evening. Hey to Nick Batez, who says, I had my third frozen embryo transfer today. This is it. Thank you for your help, Dr. Fink. My pleasure. And our heart goes out to you, Nikki. Gosh, fingers crossed that this is where the magic happens. S. Jurgens, hello, and SB Charles. Luma Digest, E. Romero, Mednicare. Hello to Angela Fox, the world's greatest cardiac nurse practitioner. Thank you for being here, and I hope you are enjoying your beautiful baby, who now must be about 5 or 6 months old or so. Love to hear these stories. Runner Girl Training, hey, how are you tonight? Green Rock, hello. E. Romero says, we just celebrated our son Emilio's first birthday. Oh, thanks to you, Dr. Fink. Oh, man. Gosh, I like to hear those stories. Yeah, boy, that makes me very, very happy. Send pictures to my Instagram, would you? I'd love to put those up and share them with everyone. That's Randy Fink MD is my Instagram. And if you don't mind everybody getting to see your beautiful child, I hope that everybody watching will eventually be able to send me a picture so that we can share that with everyone. Luma Digest says, my friend has 3 kids. Oh, because of you, doctor, I sent your info to 2 friends. Thank you. Thank you very, very much. Yes, and again, happy first birthday, Emilio. Let's see what else we got here. Angela says, what about NAD plus? Oh, thank you for asking that question, because I was just starting to answer an email about NAD plus. E. Romero says, you made an Instagram at my old clinic. I made a chicken and the egg joke during my transfer. I remember doing it. I just can't remember the joke. So now I'm going to have to look back and see what the joke was. But see, my joke is what got you pregnant. So when it comes to dad jokes, maybe there's really something to that. You need more dad jokes in your lives in order to be getting pregnant. Clearly is the only thing that I can think of here. Let's see what else. I started to say, what about NAD plus? NAD, especially in the form of an IV. So, there is an evidence-based protocol, and NAD is not part of it. Why not? Is that because it doesn't help? No, I mean, it's a very potent antioxidant, and I do think it probably has some value, but it really hasn't been studied so well when it comes to pregnancy, and particularly things like IVF. Does it really help with egg quality? And does the expense of getting an NAD infusion, and I believe you can also get it orally, but given that there are enough things that have been shown in evidence-based practice to help with egg quality that are relatively easy to come by. Should NAD plus be one of them? And I would say, I don't think so. It's one more thing to be putting in your body, so it's not something that routinely I recommend. But does it cause any harm? And the answer to that is no, probably not. Well, let's see. Can you suggest a prenatal that contains all the required vitamins? Most of them are short of something somehow. Well, so here's my thought about prenatal vitamins. And you may have heard me say this before. And so I hope if I'm being repetitive, I hope you don't mind hearing it again. The most important thing that is in a prenatal vitamin is the folic acid. Now, there are a lot of micronutrients that come in a vitamin, and are they a bad thing? No, they're probably a good thing, but there has never really been any strong evidence to say that a multivitamin every day is helpful for our overall health or well-being. And certainly in terms of pregnancy, the most important component to that prenatal vitamin is the folic acid. You are supposed to be on a minimum of 400 micrograms of folic acid for 3 months prior to conceiving. Okay, that's well and good. You could just take folic acid if you want to without the prenatal vitamin. What about all the rest of that stuff? Well, here's the story. Um, any and every prenatal vitamin will have a minimum of 400 micrograms of folic acid. All of them do. You can look on the internet and you can see that there is let's say $120 prenatal vitamin. And you would say to yourself, wow, dang, that must be a really good vitamin. And I want the best for my baby. So I am going to pay $120 so I can get that vitamin. Well, guess what happens? At the end of the day, most of that vitamin is going to end up in your urine. And that's the same whether it's the Walgreens prenatal or whether it's the $120 prenatal that you get off the internet. If I could tell you that taking that $120 vitamin would help your child become a United States senator, president of the United States, or guarantee admission to Yale, then you say, I'm going to scrounge up the 120 bucks and I'm going to take that vitamin. But unfortunately, it doesn't work that way. Most of that vitamin ends up in your urine. So the vitamin I like, I use a Thorne prenatal. Now, in your OB's office, they will have countless prenatal vitamins. I remember when I used to practice OB, we would have no less than 6 or 8 vitamin reps coming in every week trying to get us to prescribe their $100 prenatal vitamins because they wanted to say ours is the best. But at the end of the day, a vitamin is pretty much a vitamin. I do not think it's worth overspending on a vitamin. The Thorne vitamin I use as part of my protocol ends up to be about 30 bucks a month. So it's about $1 a day. I think that's fair and reasonable. Much more than that, I don't think is all that fair and reasonable because show me the evidence that your $50 vitamin is better than a $30 vitamin. And I like that Thorne vitamin because, some vitamins have a coating, so they're a little easier on the stomach. Some of them have a little extra iron, or some of them have a little extra stool softener. But by and large, most prenatal vitamins, I have to say, I think are a scam. Now, not to say that they're not good, and some of them are good, and I'm certain the $120 one is good, but is it any better than the gummy that you get from your local drugstore? I can't tell you that they are. Show me some data that says one vitamin is really better than another one. Let's see what else we got going on here. Hey to Amanda and to M. Roth, thank you for being here tonight. We've got a few more minutes on the show. If you've got any questions for me, or feel free to email them. That goes to askfertilitywithfink at firstfertility.com. What else is going on in the world right now that makes us think about things? Hey to Shada, and hey to Theme Johnson and Liz Carmen. Other things happening in the world, especially as it pertains to fertility. There's more and more talk about people or about states or the government requiring in vitro fertilization to be mandated. And those are what we call mandated states. And where I came from in Colorado, Colorado was a man or is a mandated state. The problem there is that many businesses figure out ways to be able to work around having to cover fertility. There was just an article I read this morning where there is actually from both sides of the aisle, Democrats and Republicans, fiscal conservatives and bullish liberals, and all manner of things everywhere are talking about, should we as a country make childbirth no cost to the consumer, much the way that primary care, like having a preventative checkup, should in most under most insurances doesn't cost you anything. Should that kind of care be at no cost? The estimate was that if everyone's insurance would increase by about $30 a year, which is really pretty nominal in the grander scheme of things, they think that across the board, everyone's obstetric care delivery in the United States could cost people nothing. And I think that's a very intriguing and attractive idea. What I think we should have a focus on and a real conversation about is about egg freezing. Because nowadays, most people don't talk about it. But, to be honest with you, I think, really what you're doing there is purchasing a fertility insurance policy at some point earlier in your life. I think that's a great idea. How many people out there now wish that they had done some egg freezing when they were much younger? Because you never know when you're going to need those eggs, and you may not ever need those eggs. Had this conversation, even several times in the last couple of days. There's nothing that says you ever have to use those eggs that you save. There's nothing that prevents you from getting pregnant in the normal way. It's really just an insurance policy. And I feel very strongly that we should be having this conversation much more so than we ever have in the past. Shada asks, I have Hashimoto's, and my thyroid peroxidase antibody, or TPO, that's the antibody that we measure, has been progressively going up. What is the safe range before FET? Should a transfer be canceled because of a high TPO? And the answer to that is no. I do not think that a transfer should be canceled because of a TPO, but it means that we want to make sure that your thyroid is in good condition. So the problem with the Hashimoto's antibody is that sometimes it can make the thyroid's volume knob turn up, and sometimes it can make it turn down. It can make your thyroid kind of go all over the place like that. So generally speaking, if someone has Hashimoto's, I like to treat their thyroid and have that TSH level somewhere around a 1. I think that's where we do the best, and that tends to hold that thyroid and keep it from kind of going crazy. There is no number associated with that TPO that we would say, gosh, you have to be within this range, because it can vary based on a lot of factors. It does show that you've got an inflammatory process in your body, some sort of autoimmune situation. So there may be some other things in the autoimmune protocol we would want to do with you to help quell that. Certainly something like prednisone, I think, might make good sense. But most specifically, I'd really be looking to keep your TSH at around 1. Let's see here. Linnea says, I'm 5 weeks pregnant, and they told me to stop the baby aspirin. I thought this was continued through the first trimester. There is no harm to staying on that baby aspirin. So I think you can continue it if you'd like to. Certainly, if you're having some bleeding, then I would say, it's a good reason to probably think about stopping it. But if not, I think staying on through the first trimester is a very reasonable thing to do there. Folks, we're going to be about out of time tonight, and I hope you'll join me next week, Tuesday at 5 p.m. Central Time, 6 on the East, 4 in the mountains, and 3 on the West, because the one place that you should be on Tuesday evening is Fertility with Fink. Remember, every step forward with kindness towards our fellow beings, every step forward with love, and every step forward knowing that tomorrow is a new day full of all new adventures, which means have hope, don't give up. I'm Dr. Randy Fink from Pensacola, Florida. Thanks so much for being here, and good night. See ya.